right. Hello, everyone. Thank you for joining our GHAPP MASLD Community Network meeting. Our speaker today will be Emily, and I'll turn it over to her.
Hi, everyone. Thank you for joining. I'm with the GHAPP MASLD Community Network, and today we will be discussing MASLD and MetALD. Just having an issue with the slides. Here we go. So my name is Emily Przybyl. I'm a physician assistant at the Erie County Medical Center in Buffalo, New York. You can use this QR code to record your attendance for the meeting. Let's jump into it. So our patient, our sample patient, her name is Ashley. She is a 52-year-old Caucasian female. She was referred for evaluation after she had an abdominal ultrasound showing mild hepatomegaly and findings consistent with hepatic steatosis. Sorry, I jumped ahead. I'm trying to get back. She has a medical history of PCOS, hypertension, hyperlipidemia. She reports an average of 2 glasses of wine per day. On physical exam, you can palpate the liver edge that is smooth and non-tender. For medications, we have a history of being on amlodipine, atorvastatin, a multivitamin, and milk thistle. Sorry, just having an issue going back and forth with the slides.
Oh, sorry about that, Emily. Try now. It should work for you.
Let's see.
Here we go.
Okay, so to go back, she feels well, no complaints, doesn't have any abdominal pain. So we went through this slide. Getting into her vitals and lab values, blood pressure is a little elevated, elevated BMI of 29.4, mild elevations in the AST and the ALT. And depending on your lab, that total bilirubin is borderline, and in addition to that, alkaline phosphatase. She has normal platelets. She does have an elevated hemoglobin A1C of 5.9% and elevated triglycerides above 150. So after our initial evaluation, we ordered a FibroScan, and these are the results. Lower the better, so the green is good, red is bad. Unfortunately, our patient Ashley has a KPA of 11.4, which puts her in the significant fibrosis or F3 category. For the CAP score, which is the measurement of steatosis or fat in the liver, she had evidence of severe steatosis with a CAP score of 310. So steatotic liver disease, the nomenclature changed a couple of years ago where the steatotic liver disease is our umbrella term. On our left are MASLD or MASH, or metabolic dysfunction associated steatotic liver disease, meaning your risk factors with hypertension, hyperlipidemia, diabetes, being obese, will put you in that category. When you add on alcohol use, that kind of changes the nomenclature, the picture there. When we get in the middle, so we have metabolic risk factors with increased alcohol intake, meets criteria for MetALD. Now, we can kind of break it down a little bit further, depending on their weekly or daily alcohol consumption. One standard drink is equivalent to 14 grams of alcohol, and it's a little bit different for females versus males. So for Ashley, our patient who stated that she drank 2 glasses of wine per day, so that would be approximately 28 grams of alcohol per day. So she does meet criteria for MetALD. However, on that bottom line, the average alcohol intake for her would put her in the MASLD predominant category. If you exceed those numbers to the right, the patient would meet criteria for alcohol-associated or alcohol-related liver disease. Now, we do have some outliers that can cause steatosis, meaning your drug-induced liver injury, your Wilson's disease, or inborn errors of metabolism can cause steatosis without alcohol or without metabolic risk factors. So you always want to work up and rule out other underlying liver disease, including hepatitis C. Another big one would be celiac disease, can cause elevated liver function tests and steatosis. And then there's always the cryptogenic. Sometimes we simply do not know why a patient would have steatosis or fat on imaging. So these are the equivalent for a standard drink of alcohol. Most patients are likely not measuring the alcohol. They may believe that 1 glass of wine, they may be filling that all the way up and just saying, oh, it's 1 glass of wine per night, when in reality, they're likely having more than just 1 drink. I recently, had a patient say, well, I only drink 1 glass of whiskey per night. But later in the conversation, he said it was a double. So you're having 2, and if you're not measuring, you could very easily be having 3-4 shots of liquor when you're just thinking that you're having 1 standard beverage. So we'll get into the mechanism of this. So the MASLD risk factors being your insulin resistance, your diabetes, sedentary lifestyle, and poor diet, in addition to alcohol intake, can lead to disorders with lipid metabolism, and over time can cause inflammation and scarring. And both of those can do that individually. So when you combine them, you add the metabolic risk factors and the alcohol intake, it really accelerates the process, really puts fuel on the fire. So the fibrosis is progressing much quicker when you combine those disease processes. Drivers of liver disease. So on the left, this is the risk estimates for decompensation. So it makes sense that as you have more scarring or more fibrosis, that risk for decompensation is going to be higher. On the bottom, I would just encourage you to look at the risk of decompensation, goes up along with increasing alcohol intake. Obviously, there's a lot of factors that go into this. There are baseline cardiometabolic risk factors, your genetic predisposition. But obviously adding alcohol on top of all of that doesn't help and can significantly increase the risk of decompensation. So detection of alcohol use with biomarkers. So the methods that they use to estimate or figure out how much alcohol patients are drinking. They used questionnaires. The Audit-C is a specific screening tool used for patients at risk for alcohol use disorder. They also incorporated serum tests, urine, and hair testing. And what that concluded was that about a quarter of patients with NAFLD or MASLD met criteria for moderate to excessive alcohol consumption. So obviously it's helpful to have an objective test to assess the degree of alcohol use. So the gaps in assessment, unfortunately, patients may not be very forthcoming about their alcohol use. So you work them up, you do your what we call the chronic liver disease workup. We rule out the genetic disorders of the viral hepatitis, but they meet criteria for MASLD or metabolic dysfunction liver disease. So if we go down that pathway on the left, and they have isolated hypertension or hypertriglyceridemia, you may consider doing a PEth testing, even though they deny alcohol consumption. It may be nice to do a baseline PEth testing, and then you can always repeat that in the future, to trend that over time and really encourage them to decrease or completely abstain from alcohol use. And then when we get to the right, we can also use that testing to further characterize them into MetALD versus ALD. So we did get a PEth testing on our patient, Ashley. Her PEth was 120. So for her, that puts her in the moderate to heavy alcohol consumption. So our PEth, I can't say it, so that's why I usually just say PEth. It's detected for 3 to 12 days after one single binge. The mean half-life is 3 days. So obviously, your blood alcohol testing or your ethanol testing, that half-life is very short. So even in 12 hours, that's likely going to go back to normal. So this PEth testing gives us a broader range to assess for weekly or chronic alcohol use. And it is a serum test that you can order at LabCorp or Quest, whatever lab that you use. And there's no significant variability for sex and BMI, so pretty accurate across the board to use and even trend. And this was a study where they assessed alcohol use in individuals with excess weight. So they were screened and excluded if they had any underlying, other chronic liver disease, such as viral hepatitis or HIV. They were excluded. And then down at the bottom, 97 were analyzed with suspected MetALD. And 15.7% were at risk for that diagnosis. To go back to our patient, Ashley, just as a reminder, her medical history includes PCOS, which is commonly associated with insulin resistance. She has a history of hypertension and hyperlipidemia. The association between alcohol and hypertension, alcohol has a biphasic effect on blood pressure, meaning that initially blood pressure decreases for about 12 hours after consumption, but then increases after 13 hours. So as you can imagine, someone that drinks alcohol on a daily basis, your blood pressure is really doing a roller coaster where it's bouncing up and down. On the right, you can look at specifics on the changes in systolic and diastolic blood pressure, in addition to the heart rate that's being affected here. Alcohol and hypertriglyceridemia. So again, alcohol is affecting your triglyceride concentration over 10 hours after administration of 2 standard drinks or water. So on the top graph here, those are our hypertriglyceride group. So as you can see, the blue are the patients that drank or consumed alcohol. So much higher than the group that drank water. And similarly, for patients that do not have a history of hypertriglyceridemia, the alcohol consumption is still going to temporarily increase that triglyceride level. And on the right here, I believe, it's the non-hypertriglyceride group really significantly spiked and then dropped and compared to the hypertriglyceride group, which is interesting. So as to recap, Ashley, she's our 52-year-old patient, referred for mild hepatomegaly and steatosis on imaging. She drinks 2 glasses of wine per day. Our FibroScan or transient elastography, significant for F3 and S3. Her lab work, showing mild elevations in the AST and ALT, borderline bilirubin, but elevated hemoglobin A1C and triglycerides. History of PCOS, hypertension, hyperlipidemia with an elevated BMI. So our diagnosis, she meets criteria for MASLD, but she is predominantly MASLD MetALD. That's a little wordy. So what do we do? What do we recommend for Ashley? First and foremost, we recommend dietary modifications, specifically a Mediterranean diet. Recommend exercise and overall weight loss or mass reduction. She would be a candidate for resmetirom. Yes, she meets criteria for MetALD, but she's on the MASLD predominant side of that. And in terms of alcohol use, I would encourage her to completely abstain from alcohol. I know obviously that can be difficult for patients, but trying to explain that she's F3. If she doesn't make these changes, she will likely become cirrhotic in the next few years. So it's really trying to drive home that this is the time to make the changes and hopefully reverse some of that fibrosis. And she absolutely needs HCC screening. For someone that's F3, I would typically recommend doing an ultrasound or imaging every 6 months, since they are at higher risk for HCC. So ideal MetALD definitions, we want to overcome the underreport of alcohol use. Obviously, we want patients to feel comfortable to tell us or accurately describe their alcohol consumption in order to best understand their liver disease and best help them. We want to standardize the assessment for recent alcohol use, and we want to objectively, certify that the patient has been abstinent. And we want to ensure the drivers of liver disease are present. If they have at least one cardiometabolic risk factor, and ensure persistence of hypertension or hyperlipidemia after they stop drinking alcohol. Basically saying that are those conditions directly related to the alcohol use, or are they still present without alcohol consumption? And they need to meet the criteria for 6 to 12 months. So you may have a patient where their alcohol use varies greatly, meaning, you may have some patients that drink every day for a month and then they quit for a month. It may not be as straightforward as we would like it to be. But ideally, they need to meet that criteria for 6 to 12 months to make that diagnosis. Our take-home messages: MetALD, meaning alcohol consumption beyond 140 to 350 grams of alcohol for women, or 210 to 420 grams per week for men. And again, one standard drink is approximately 14 grams of alcohol. And we're likely underestimating the patients that meet criteria for MetALD and even alcohol use disorder. Patients may not be forthcoming with their alcohol consumption. They also may be overpouring. They may think they're only having 1 glass of wine or 1 shot of alcohol, but they're overpouring it. So the PEth testing offers an objective way to accurately assess how much alcohol they're consuming. And then over time, you're going to want to reassess their metabolic dysfunction, reassess their hemoglobin A1C, redraw that lipid panel to see how they're doing in that aspect as well. Want to consider adequate exposure to risk factors and different sociocultural differences there. If you would like more disease state education, you can scan this QR code to go to the GHAPP MASLD and MASH Community Network. And of course, we'd appreciate your feedback. There's another QR code for you.